this is a talk that I've done before, and we find that androgen deprivation therapy, Dr. Chow pointed out that the androgen receptor is the most common genetic feature in prostate cancer. So that targeting the androgen receptor becomes common across almost every disease state. And so we found that it's very useful just to review it. And so that's what I'm going to do. So ADT stands for Androgen Deprivation Therapy. I hope most of you know that, but perhaps not. So prostate cancer cells, wherever they're found in the body, in the prostate, in the lymph nodes, in the bone, at the tip of your nose, doesn't matter where they are, I've lumped them all together, depend on the male hormone testosterone to survive and grow. There's no cancer, by the way, known to us that is more dependent on a growth factor than prostate cancer is dependent on testosterone. So it's an absolute driver. The main source of testosterone is the testicles. And the testicles, in turn, are stimulated by a sequence of hormones secreted by the hypothalamus and pituitary glands at the base of the brain. And so there's this cascade that stimulates the testosterone production. In the 1940s and 50s, it's stunning. It's almost been a century. Dr. Charles Huggins, who was a urologist at the University of Chicago, discovered that getting rid of testosterone, he did it by surgically removing the testicles, called an orchiectomy, led to significant regression of prostate cancer. And it used to be, this is changing a little bit, but it used to be that almost any talk that you ever heard about advanced prostate cancer would show this picture of Dr. Huggins, right? So it's the same picture. We all have it circulating around. It's probably not even what he looked like. I did hear, and Peter, we may have shared this person. There was a physician who I took care of who had been a resident with Dr. Huggins and said that he was awful in the operating room, that he was terrorized his staff. So nevertheless, I don't know if we shared that patient, but it was and at the time, the fellow that I had was like, oh my God, you know Dr. Huggins. I mean, he really is the father of what we do in many ways. And this sentinel observation earned him a well-deserved Nobel Prize in Medicine. So androgen deprivation therapy follows up on this observation that he made, that if you get rid of testosterone, the prostate cancer cells die. And by the way, when Dr. Huggins tested this, he did it in patients that had very, very, very advanced disease, widely metastatic throughout their bones, with excruciating pain, weight loss, loss of appetite, people who were in really deep trouble. And he would do this procedure and it was miraculous. The cancer would melt away. So ADT refers to eliminating testosterone produced by the testicles. It can be accomplished by surgery, but it can also be accomplished by any number of drugs listed here, and I'm going to walk through them, that block the signal between the hypothalamus and pituitary. You just block the signal, it doesn't get through to the testes. And it's important to understand that it doesn't matter which approach you use, they're all equally effective. So that said, while there's no difference in the efficacy of the hormonal agents, there are some differences between the agents, and I've listed the ones that are used here. So how they're given, Leuprolide or Lupron, Goserelin or Zoladex are shots. Lupron is an intramuscular shot given in your buttocks. Zoladex is a shot, a pellet that's placed under the skin in the abdomen. Degarelix is a subcutaneous shot. Relugolix is a relatively new approach, is oral, it's a pill. And we'll talk about the pros and cons. Again, they work equally well. How often? The Lupron is available as 1, 3, 4, or even 6-month injections. So it makes it very convenient. The patient doesn't need to come into the physician's office except at those intervals. I must say that at UCSF, we tend to use 3 or 4 month shots because our therapy is done in 3 or 4 month increments, but these are all available. The Degarelix, and I'll show you its advantages, also known as Firmagon, has a disadvantage of it being available only as a monthly injection. So if you do use it, it's once a month. With regards to concurrent treatment, I'm not going to spend a lot of time on this, but when you start off a medicine, some of these result in a transient bump in testosterone before it declines. And so you need to guard against that, typically with a pill that prevents that from doing its damage. And so that holds true for leuprolide and goserelin. The big advantage of drugs like degarelix and relugolix is that they don't have that bump in testosterone. So you can just give the drug, it's rapid and it works quickly. And so these are great drugs if you need rapid onset. Not everyone needs rapid onset, but if you do, they're very useful. This is a little sketchier data. It's not quite as validated, but there is reasonable data suggesting that for men who have active coronary artery disease or ischemic disease, so this is not the run-of-the-mill patient. This is a patient who's had a heart attack, who has ongoing angina, who had a recent stroke or TIA. In those patients, there appears to be a reduction in risk of what are called MACE, major adverse cardiovascular events, when you use one of these two drugs. So if that is operative, we will certainly go to these drugs. The data does not support using them to prevent cardiovascular events, at least, in patients who don't have an underlying cardiovascular history. And then there's some other issues. The degarelix shot, the Firmagon, can be painful. It's given under the skin, and patients will notice big red welts. It tends not, for that reason, not to be a very useful maintenance drug. Some people choose it. They just prefer it. But we can start with it because you don't need to use the other pills and then switch over. The relugolix, the pills, it's a daily pill, which is good and bad. You have to take pills every day. And if you miss it, it can have a significant impact. The nice thing about the shots is you do it and you forget about it. There's a rapid onset, but also a rapid offset, which means that if you're counting on things declining slowly, that might not be the medicine. And these are all the considerations. Relugolix is a pill, so you have to deal with cost issues and what your copays are, whereas the injections typically it's lower because Medicare and insurance companies cover that. But those are the considerations. These are by and large interchangeable. Now, if we do one of these things, shown in the red X's, and we measure the testosterone that is inside the prostate cancer cells following ADT, it ain't zero. It's somewhere in the 10 to 20% range. And they can contribute to continued growth of the prostate cancer. And the reason for that is that it is the adrenal glands. Oh, let me do that again. I forgot I had a sound on this. Check it out. I forgot I'd done that. It's the adrenal gland doing its thing, squirting out the testosterone. Exactly. You guys, simple pleasures for simple minds. What can I say? So the adrenal glands, which normally are involved in mineral, sugar, and blood pressure regulation, produce a small but significant amount of testosterone. And it can be blocked by approaches that are called anti-androgens. And I've listed them here. You'll be hearing more about these. The first three, flutamide, nilutamide, and bicalutamide, are termed first generation. And they're somewhat less effective because they block, but then fall off. Block, fall off, block, fall off. Whereas the second generation, enzalutamide, apalutamide, and darolutamide, and we've had a role in developing apalutamide in particular, block and stay put. And so they're more effective. But it doesn't matter how you do it. Any one of these is very effective in blocking that 10 to 15% extra testosterone. And I'm going to show you later that that's actually a useful thing to do in some patients. Another approach is just to shut down the adrenal production of the testosterone with a drug that we also developed at UCSF called abiraterone, or Zytiga. And all of these drugs are now FDA approved. I realized when I put these slides together that I didn't have a comparative table for these drugs as I do for the others, but we'll be able to talk about them. As a group, these agents that deal with the non-testicular or adrenal sources of testosterone, you'll hear them called androgen signaling inhibitors, ASIs, or androgen receptor signaling inhibitors, or RCs. So if you hear people use those terms, that's what that means. It's kind of weird when we say androgen deprivation therapy, we really refer only to reducing the testicular androgens, not the adrenal androgens. So it's just a funny part of the nomenclature. So just when you hear ADT, think testicular. When you hear ASI or RC, think adrenal. I'm not going to spend a lot of time on the ADT benefits because we'll be coming back to this throughout the morning. So I'll skip through this for now, other than to say that it's used all over the place, and you'll be hearing from our experts. That's great, but ASIs have consequences. And you will also be hearing both in our patient panel, as well as from specific speakers about some of the consequences of ADT, and they're not trivial. These are what we see both on the symptomatic and silent side. I'm not going to walk you through each one of them right now. I do want to say that no one patient has every single side effect, and no two patients share the exact same side effect profile. And in fact, the genetics and genomics that we were talking about earlier probably contribute to how you experience ADT. I always tell people, think of it sort of a bell-shaped curve. About 15% of patients will have almost no side effects, to the point that they say, are you really, where's the beef, doc? Are you really giving me this medicine? And another 15% on the other end of the spectrum say, holy moly, you didn't tell me it was going to be this rough. I got to get off this stuff. And about 70% are in the middle. And the middle is very variable. So it could be, for example, someone is fatigued but has nothing else, or someone has hot flashes and nothing else. So I don't want you to assume that these are necessarily all operative. They're also very time dependent. The longer you're on hormones, the more likely you are to experience them. So you'll hear, in fact, right now, that we try to reduce those side effects. So how do we reduce side effects? Well, there's the easiest way to do it is what we would call treatment de-intensification, and I'll talk about that in just a second. In general, that's something that we can undertake in patients with less extensive disease or that have lower risk disease, which is why some of these markers that you've heard about are so important. If your markers tell you that you're really low risk, then maybe you don't need a lot of hormones in that particular circumstance, and you'll be hearing about that. The flip side also holds true, which is how do we maximize benefits? And we would call that treatment intensification, and you're going to hear very specifically about that later today. In how we combine hormonal therapies. And treatment intensification in general is undertaken in patients with more extensive disease. So if there's a patient who has high Gleason score and a very high Decipher score and a PSMA PET scan that shows a number of spots, we're going to want to be thinking about intensifying therapy. So those are the principles that we're always balancing and individualizing. How do we reduce side effects? What's involved with treatment de-intensification? Well, certainly you can choose, and we'll come back to this, between using ADT alone or adding an ASI. That's one. Now, a lot of times people will say, well, can I take half the dose of the Lupron? Maybe I don't need it that much. And it turns out that the side effects from these medicines are not due to the Lupron. It's not due to the Casodex. It's due to the low testosterone. So that reducing the ADT dose itself simply leads to less testosterone suppression, which might lead to less side effects, but it also leads to less effective therapy. So it's not a very viable strategy. Therefore, the best way to reduce side effects is to shorten the duration of ADT and perhaps to avoid the ASI. So shortening the duration, you'll hear about this later when we combine hormonal therapy with radiation, and you'll be hearing in that session, we will adjust the duration of hormones based on the risk. So it's super, super low risk, you may not need any. If it's very high risk, you'll need more. An important strategy, and Dr. Cooperberg told me there was already a question about this early on online, for reducing side effects or treatment de-intensification is something that we've termed intermittent androgen deprivation. And different people do it differently, but in general, the principle is you do a year's worth of ADT and then you stop. And you stay off ADT for as long as you can until the PSA starts to climb again, and then you go back on it. This becomes much more complicated, and you'll hear from Dr. Hong later today on, in those settings, using targeted radiation to hit those few little spots that come up during the time that the PSA is climbing. But in general, a year on, a year off, more or less, is very efficacious. The literature suggests that in patients who don't have well-established extensive metastatic disease, that it is at least as effective as continuous, perhaps better, and it certainly eliminates the side effects while you're on the drug, while you're off the drug. So it's a useful approach. An added benefit is that it appears to delay the time to hormonal resistance, and we'll be talking about that later as well. I should say that the standard of care with intermittent androgen deprivation therapy is in patients that do not have extensive metastases. That in patients with extensive metastases, the standard of care is continuous therapy. So in terms of maximizing benefits, excuse me, that's treatment intensification. We want to reduce the amount of available testosterone as low as possible. And so that's when adding an ASI, like I just told you about, or an RC, is useful to get rid of the testosterone contributed by the adrenal glands. And we actually call this ADT intensification, and I'll be speaking about that later today. It's become a standard of care across almost all stages of prostate cancer. So I think the things to think about with androgen deprivation therapy is the balance, and to do the calculus. Is it needed at all? What's the best timing of it, the duration, and the intensity? This is an important part of shared decision-making, because we, with you, have to decide what are the likely side effects, what are the actual side effects in you as an individual patient, because you may be surprised and not have any, and then how does that inform our therapy, our therapeutic recommendations? And I always tell people this is very dynamic. We don't have to decide up front. We embark on the therapy, and then as we're going along, we make that decision. I have one more slide that I put in here as an instructive slide more than anything, because you've already seen some of these plots, and I want to make sure everyone is comfortable with them in case you see them elsewhere. So I've already told you that ADT intensification might be a way to improve outcome. So how do we measure outcome in clinical trials? That someone had questions about. This is called a Kaplan-Meier survival curve, and you'll see these flashed around a lot. And not everyone knows how to read them, and I want to walk you through it so when you see them, it's kind of intuitive. On the y-axis is the percentage of patients that, in this case, are alive. So it starts at 100%. It could be the percentage of patients who don't have a new metastasis, or the percentage of patients whose PSA hasn't progressed. It doesn't matter what the endpoint is. You always have to ask and read. I saw someone leaning their head over. You want to see what it says. Overall survival. So it starts at 100%. Typically, in a clinical trial, in later stage clinical trials, we randomize patients to one of two treatments. And they're shown in different colors. Dr. Chow tried to confuse you with two studies, one where the red and the blue were superimposed. One is typically the intervention, and one is typically the standard of care. And I will tell you that for phase 3 studies, you'll hear more about this along the way. For randomized phase 3 studies, the control arm, the standard of care, is never below the standard of care. People say, "Oh, I'm going to get a placebo." It is you might get a placebo and you're not getting the treatment the experimental treatment, but you're guaranteed to get the standard of care treatment. So enrolling on a clinical trial, a key requirement by our review agencies and the feds and so forth, is that no one on that trial doesn't get standard of care at a minimum. So in this particular case, oh, and then I'm sorry, along the x-axis is time. How long have you been following it out? And obviously, it depends on what you're looking for. You know, in a survival study, you're going to see this go out to 60 months or beyond. In a time to PSA progression, depending on the setting, it could be 5 years. So it depends, and it's important that you see what that axis is. On the very, very bottom, you will see numbers that refer to patients who are at risk. Basically, what that tells you is that as patients have an event, in this case, death, they get taken out. They no longer count. And so you can see that as you get down to the bottom, the numbers get very small. And so the difference is a little bit harder to interpret. The first thing that we do with these tests is the eyeball test. You know, can you drive a truck through those curves, between those two curves? Here you can. If the curves are completely superimposed and you're really struggling to slip a microscopic something in between, it tells you that the results are very similar between the two arms. In this particular trial, the yellow curve is intensified ADT plus abiraterone in a certain proportion, in a certain group of patients. Whereas the white line, standard of care, back then, was ADT plus placebo. The other outcomes besides the eyeball test that people will look at is the median time to event, in this case, median survival. And the way that's calculated is you go to the 50% mark, which is where the dotted line is, and you draw the line across, and you see what proportion of patients or how long it takes to hit that 50% mark. And so what you can see here is that the median survival for patients treated with intensified therapy is 53 months. You just read it up here. Whereas with the placebo, you read up, it's 36 months. These are numbers that the FDA looks at. The FDA's, the first thing they'll look at is median time to event, median survival. So here you see that the overall survival is 16.8 months longer in one study versus another, and that's significant, obviously. There's two tests to be aware of: what is clinically significant and what is statistically significant, and what the FDA thinks is significant. In this case, it's all three, right? So we would all agree this is clinically significant. It is statistically significant, as shown by the p-value. And in fact, the FDA agreed and approved intensification. So that's how we look at these studies. The other thing I will point out is that if you see curves that are crossing over each other all the time, that means it's hard. Even if they separate out at the end, there may not be a huge difference. But the profile of the curves is important. There's some times where the event, what you're doing, the intervention has a late effect. I should have put an example of this. So the curves are superimposed, and then they split. And the median may not reflect that split. And so that split over time, where you basically look at the whole curves over time, is called the hazard ratio, or HR. And the lower the hazard ratio, it's the risk of death, the better. So in this case, you have a 66, so it's a 34% improvement in risk of death by adding abiraterone. Okay.
Hi, on your last slide, it would seem to me that the intensity of the disease has a big effect. So, I don't see how the treatment alone can explain the difference, because somebody in the placebo group could have had a much different intensity of
right.
disease.
Great question. So that's a great question. So for folks online, is what's the impact of the disease itself on these curves? If you have high risk, low risk, whatever. And the principle of a phase 3 study, which this is that patients are randomized, meaning they come into the study and they are told there's a 50-50 chance or whatever that you're going to be randomly assigned by a computer, not by you, but not by the doctor, to receive placebo or to receive active drug. And what that does is that it ensures that there is a balance across both trials to ensure that the risk profile is identical. In fact, what I didn't show it to you, but what all studies like this do is that then they report, in this case, on the 1,000 patients, 1,200 patients that were enrolled, and they show you the normal risk characteristics: extent of metastases, location of metastases, Gleason score, PSA score, everything that is known to us as a risk factor. They show it in the table, and it is demonstrated that it is no different from one group to the other, i.e., that randomization was successful. There is always the risk that there is an unknown factor, the Peter Carroll risk factor that hasn't been discovered yet, and that by chance, randomization didn't allocate it evenly. But the chances of that are really low, and that is assumed by the statistical significance of the study. Does that answer your question? Great question.
It does. I also see they didn't live that long.
So I wouldn't focus on the duration here because it depends on the scenario, right? Again, patient in, patient out, So if these patients were men whose, the control arm, in fact, this is men whose average survival is 3 years. But I haven't told you anything about who these patients are. It could be that the study included patients, all of whom had liver metastases, right? I didn't tell you that they were patients with localized disease or not localized disease, which is why it's really, really important. There's two separate questions here. Is what is the x-axis? If that was 20 years because we were looking at the role of radical prostatectomy versus something else, you would see something different. So it really depends on the patient group that you're seeing. And it's important that we have a control group, right? Because if we had done this study with just the top arm, we'd be either upset or congratulatory, whatever, but we really wouldn't know what we were comparing to. So that's the value of phase 3 studies. I will tell you, we're not going to have a specific session on clinical trials. We used to do it at the beginning. The way drugs are developed, phase 1 study is first time you're testing it and you're just learning. What is the side effects? Is it effective? Phase 2 is you do just one arm and you say, oh, when you add abiraterone, it looks pretty good compared to historical controls, but it has exactly the first question you asked, which is like, how do you know that you didn't choose bad patients or good patients? And so you answer that question, and the FDA demands that question be answered with a randomized phase 3 study. So this study, putting aside the absolute duration, tells us that this drug is very effective, that this strategy, it passes the Mack truck test. Would you mind passing your mic right behind you? We have time for one or two more questions.
It's about the intensification,
right?
Right, if I can say it. Were there any trials comparing the three different aspects of it: side effects versus efficacy versus the sensitivity to ADT treatment, depending on strategy? Meaning, when you are using ADT, you're trying to decrease testosterone by X%. Instead of doing year on, year off, decreasing not by X%, but by half X. And how does it compare against each other?
Yeah, that has not been done, in part because using ADT is an on-off effect, right? It either shuts down the signal that goes to the testicles or it doesn't. So testosterone either falls or it doesn't. So that strategy to de-intensify has not been able to be done. Now, what could be done, it's not been done a lot, not in this setting, clinical trials, is to say, well, we're going to ablate testosterone and then we're going to give a little bit back to give you that 50% mark to compare. And that has not been done in hormone-sensitive disease. In hormonally resistant disease, that approach, which is called BAT, which is bipolar androgen therapy. So you go up and down, and the testosterone has been tested. It gets to your second question, which is whenever you're comparing these, in addition to having in the papers, there being a table comparing the patient characteristics, there's a table comparing the side effects, right? Because you want to make sure that if there's a lot of side effects that gives you that increment, then that goes into the decision-making process. Is this worth it? Both on a personal level, but also for the FDA. In the case of BAT, there's a lot of side effects. And so if you look at those tables, in some patients, it's actually potentially dangerous. And so you have to balance those two. So that's a really good question, that not only do we look at efficacy, but we definitely, that's the first step for the FDA, is efficacy. But then this is what goes into our discussions with you, is we say, when I talk to a patient about a clinical trial, I say, hey, this clinical trial showed us that intensification is the way to go. However, here's the price.
For men getting radiated, though, we've done 0 versus 3 versus 6 months of hormone therapy with radiation. We've done 4 months versus 28 months, 18 months versus 36 months.
Right, but that's
duration of hormone
right.
therapy in the context of treatment.
So a form, so Mac's absolutely right. A form of that I mentioned, a form of de-intensification is duration, for sure. And that you'll hear more about that. But in terms of the actual level of testosterone, that has not been done for the reasons I've described. Last question in the back. Mac, would you mind walking the mic up back there? Thanks.
Yeah, in terms of reducing side effects, are there any studies showing non-pharmacological interventions like exercise or nutrition that can help reduce those side effects that we see from the hormone therapy?
Yes, and we'll talk about it later. We have a whole session on it. All right, thank you very much.